Now, on to the next part of the agenda, which is to introduce and launch the Child and Youth Mental Health Scorecard. And I'm really delighted to introduce two terrific people that I'm very fortunate to call friends and colleagues. First, Dr. Astrid Guttmann. Astrid has been a part of ICES for a long time, since 2001. Started as a fellow and is now the chief science officer and a senior scientist at ICES. She's a staff physician at Sick Kids and has played numerous leadership roles in many venues, including in child and youth mental health. She holds a Canadian Institutes of Health Research Applied Chair in Reproductive, Child and Youth Health Services Research, and she sits on the Provincial Council for Maternal and Child Health in Ontario.
Thank you, Michael, and thank you to everybody for being here. I just wanted to reiterate Michael's comments about how pleased we are that so many of our partners, provincial and federal ministries, as well as partners from care organizations, that you are here. Because really, we see ourselves as one, I would say, small piece in a very large puzzle, and already the conversation has started about, how do we improve? And so we're very pleased to launch the scorecard, but in the recognition that we're really here to to serve the sector and to, shed some light on where there are problems, to try to develop more integration across sort of both within, the health sector, but then also beyond, really with the goal of, improving mental health outcomes for children and youth, and then Paul will speak to adults. As many of you know, this work emanated from the Ontario Mental Health Strategy. So we were really funded at the beginning of that strategy, which focused on children and youth, for the start thinking about how we might measure both the state of mental health for children and youth, and also the progress made by the mental health strategy, but as we've heard from Minister Bell as well, other large-scale strategies such as the Patients and so we released our first scorecard in 2015, and at that time, we were well aware that although we were excited that this was a first provincial, look at a number of the issues facing the system and facing children and youth, that we were fairly restricted to the data that we had, which was really mainly focused on the healthcare system. And we are all extremely aware that, mental health is important across many different sectors. We have all of the community-based services that are funded through the Ministry of know that schools play a huge role in the identification of children mental health problems, and we know that other sectors, the justice system, social services, et cetera, are all very, very important. And so we have been very cognizant that in order to do robust measurement, we need to be engaging with those partners, but also trying to integrate as much as we can some of those data with the healthcare data, so that we actually are reporting in a way that's meaningful. And so we're very pleased in this report that there are now measures that came from MCYS and the transformation that's gone on in that system with the new lead agencies, and I'll allude to a little bit of some of the other progress that we've made in working with other data. Sorry, I feel like my voice is going on. And then our Director of Data Partnerships later in the morning is going to also talk about sort of the data strategy that we hope will mean that our continued work in this area will become more and more robust. Just a few notes. In your folder, you have a summary of the scorecard, and then there's a short report available on our website. Later in the summer, we're going to release a very long chart pack And again, we have a fixed number of indicators, but we try to report these in ways that are helpful, you know, in a number of different ways. And so we are reporting these indicators by LINS. We will report these indicators as well by the MCYS lead agency catchment areas. And although we're not doing this in a public naming way, we've had good advice that for a number of the indicators, you know, being able to feed data back to providers, so hospitals, for instance, will be very important. So we are doing that initially at the, you know, within peer groups, so large community hospitals, tertiary hospitals, but we're very open to sharing those data with LINS and with the providers, again, in the hopes that these data will be useful for improvement. I'm not going to go into a lot of detail about each of the indicators, but I just want to highlight a few things, and these are really that, you know, healthcare use is healthcare use, and knowing what it means is not always straightforward. So we list a lot of these indicators as being contextual. So for instance, when we track, you know, the number of visits that children make to psychiatrists, and these go up, is that a good thing or a bad thing? Does that mean that more children have mental health problems? Does that mean that more children are getting access to specialized care? Probably a little bit of both. And so again, you know, some of these indicators are complex to interpret, and a little bit of what I will speak to is as well a lot of the other work that we've been doing within the mental health program that Paul leads to really try to contextualize, you know, both the individual indicators, but what these mean sort of together, and what we're seeing. We do have indicators that we've tried to map onto what were the three main themes of the mental health strategy. So access was a big part of that. And again, you can see, you know, we with the ICES data, you know, really only have, you know, one indicator that we think is probably a measure of access, but really which speaks to how important it is that now the community-based system and the indicators that MCYS has shared in this report, and it have brought into their performance management strategy around wait times for services, you know, how incredibly important that is. It was probably the number one, you know, issue, you know, faced by and that the mental health strategy tried to tackle. And so again, very important that we're making headway in our ability to sort of have any visibility into access issues. Quality, again, quality of care, Minister Bell spoke about that. We have a few indicators and again are reporting those at the provider level. And then early identification was on another platform of the mental health. Just putting it together, we thought, you know, there are a number of indicators, and we picked out a few themes, and I'll speak to these in a bit more detail. So the first theme is really, we are just seeing, you know, a very large increase in the amount of medical service that children and youth are seeking for medical. And this includes service in doctor's offices, in emergency departments, and in hospitals. So we're just seeing a lot more of that, and that's, you know, a first main theme. Second, and you know, Minister Bell spoke about this a little bit, is this issue of integration. So we've already started a discussion, and Ms. Moran's already, you know, has spoken already this morning about this. You know, the issue of having, you know, two ministries that are tasked with serving children and youth around mental health is complicated. But even within the healthcare system, we have clear indications that the way in which children and youth are served, if they're seen in the hospital setting and in physicians' offices, is not very well integrated, and I think a very important for more work. We see that access to care is certainly influenced by sociodemographics, but really importantly, probably, and more importantly, when we look, you know, regionally, we have areas in the province that have very high needs, and you know, I'll show you some indicators to illustrate that, but these are areas that also have probably the worst profiles of service use and specialized service use. So really a fairly strong mismatch between need and service. We are reporting on these new MCYS performance indicators. We think this is a huge step forward to our understanding of how children and youth are doing in the system. And I will show some pilot work as well around not just reporting on that system, but what happens when you actually integrate. So when you integrate data and you begin to understand how children are transitioning between the two systems, what some of their care trajectories are, and some of their outcomes in one system or the other after care. And then finally, I'll just report a little bit on some of the measurement that we've done that really speaks to some targeted investments that were made as part of the mental health strategy. The first theme is just way more care seeking. So you have in your packet some of the infographics that we've developed to try and bring together some of the different themes, but we are seeing clear increases. So over a time period, over 50% increase in the number of emergency department visits as well as hospital admissions for mental health. And many of these, when we look at, diagnoses, many of these, top of the list, are for anxiety. We look a little bit at, how this plays out in different populations. Many of our indicators we are able to link to neighborhood census level data, and when we look at how this plays out in terms of socioeconomics, we certainly see higher rates of both emergency department visits and admissions in lower income children. So lower income is to your left, and in the blue are emergency department visits and admissions. In terms of the emergency departments, this is something that CIHI has reported on this as well, and we've been tracking this for a while, and we wanted to do a little bit more detailed work into this phenomenon of this, fairly substantial increase in the use of emergency departments by children and youth for mental health problems. So the first question we asked is this just more use of emergency departments writ large, and in fact, no. So it is clearly for mental health and addiction problem, and this is not paralleled by an increase in the use of emergency departments by children and youth for other problems. Second question we asked is this, are these more children, or are the same children just using the emergency department more? And it's definitely more children. The next point is, we wondered about, was this some kind of a substitution effect? So is this that children can't get care in other venues, such as primary care? And so, are we seeing in this increase in emergency department visits an increase in those that, are not deemed very acute, so where children and youth could sort of easily be seen in a different venue, and that's also not the case. So we're actually seeing, with this increase in overall emergency department visits, an increase in the acuity as well as the admissions. And so, speaks to the fact that these are, that this is not just some kind of a substitution effect. And then when we've looked in general at the use of outpatient services, we see an increase in those as well. And similarly, when we wondered whether some of these emergency department visits were because children weren't able to access care by their primary care physicians or by other physicians for mental health, and that's not the case, because in fact over the same time period we're seeing higher rates of children who have been seen prior to been seen by physicians prior to arriving in the emergency department. So, we think very clearly that this is, not just issues around accessing other kinds of care. And putting it together, what does this mean? So, we think it's probably a combination of some of the work that's being done to reduce stigma, and that's a good thing. So, there was, this may well be measuring previous unmet need, and children and their families are coming forward for care. But we do think that this is probably a signal as well that more children need care. Very clearly, and that needs to be, addressed by our system. Moving to the sort of transition between the different care within a system, we highlight just a few of the indicators. So. That we think measure this. So when we look at whether or not children who are seen in the emergency department bounce back within 30 days, whether children who are admitted to hospital again are readmitted in a short time period, to us that's a signal of how well the hospitals are integrating and transitioning children back home. And a clear piece of that would be how well they're cared for once they leave hospital. And what we're seeing is increases in both of those kinds of bounce backs, but at the same time, we're not seeing any increase in the number of children who are seen by a physician in the 7 days after they are admitted to hospital. And really stepping back, to be admitted to hospital, means you are very sick. We have very few hospital beds in this province and in this country in general. And so for overall, for children, for fewer than 50% of children to be seen by a physician in a week after being admitted really, to us, signals kind of a failure of our system being able to integrate properly. Access to care varying by sociodemographics. We reported on this last time. This is not exclusive to mental health problems. But certainly we do, I showed you already data suggesting that children from low-income neighborhoods are much more likely to need care in an emergency department or be hospitalized. When we look at some of their outcomes of care and their bounce-back rates, those are higher for low-income children. But at the same time, when we look at what kind of physician care they are able to access, low-income children are less likely to access more specialized care from pediatricians and from psychiatrists. So again, I think showing a mismatch in terms of access to care by socioeconomic. And we're fortunate to have some of our partners from the Federal Ministry of Immigration here, and we've had a long partnership with that ministry, and we're very fortunate that we're able to look more closely at children and youth who are newcomers to this country and by immigration status, so whether they are refugees. And we see an interesting picture in this group. So on the one hand, when we look at whether or not children and youth who are in emergency departments have been seen previously by physicians, we see lower rates in immigrant children and youth. So they are less likely to have sought care previously. But then when we look at their follow-up rates, they actually have better follow-up rates. And when we've looked at this a little bit more closely, and this was a paper that we did about this whole phenomenon of children whose first contact with the system is in the emergency department, we saw that there were many layers to what might explain whether children were able to access care prior to being so sick that they needed emergency department care. And we see the importance of primary care. So children and youth with very poor affiliation to a primary care provider were, of course, much more likely to have their first contact in the emergency department. But then when we dove even deeper in terms of primary care practice, we found, interesting findings around primary care physicians who provide a lot of mental health care. So primary care physicians who provide a lot of mental health care, their patients are less likely to be showing up in an emergency department without having accessed primary care first for their problem. And tying that back to the immigrants and refugees, we think that there's a whole context that goes on within primary care around, how comfortable families are to bring these issues to the fore. We think that providers and primary care providers and the education around, child and youth mental health services, and particularly in the context, in cultural contexts of new immigrants, is probably very important. Then moving to again, another area of mismatch between, where there are needs and where there's service. So, we've reported, and when the full chart pack comes out with all of the LIN and MCYS agency regional analyses, you can see, how geography plays into what we see. But we have a number of measures that we think are clear signals of need for services. So neonatal abstinence syndrome is a problem of infants whose mothers are on opioids during pregnancy. Many of them are under treatment. Many of them are on replacement therapy, but nonetheless are on doses that are high enough that the infants are born with withdrawal symptoms and need to be treated. And we've seen in Ontario a very, very stark increase in this. That's clearly related to the overall opioid crisis. But when we look at this regionally, much higher rates of this problem are in our northern LINs. When we've looked a little bit closer, and this is more in-depth work that we're doing and looking at these mothers, we know that these are high-risk mothers, more likely to be teenage mothers, and their outcomes are terrible. So much higher risks of, they're much more likely to have other mental health problems, much more likely to die early, which has obviously significant implications for the children and their families. Further to the geography, need, and service piece, I'm going to show just a few maps where this is now a map of emergency department visits, again, a signal, I think, of need. So the darker areas are areas where there are higher rates by population of emergency department visits. Similarly for admissions. And then this is physician visits within 7 days after hospital discharge, which we again think is a measure of access. I'll put them together. So essentially what you see is on the two measures of need, where the dark areas in the province, and then when you look at measures of access, it's really the inverse. So the areas of the province where we have very, very high needs are precisely the areas of the province where we have less access to appropriate mental health services. We do see some improvements, but again, geography plays a big role in this. So suicide rates have thankfully stayed fairly stable. In some areas, they've actually gone down. So in the Toronto Central LIN, they have decreased, but in areas of the north where the overall rates are still very high, they've either stayed the same or increased. So again, and we've spoken about this already this morning, regional approaches are going to be very, very important. Moving on to the community sector. So again, you'll see in the report, there are now 13 performance measures for accountability purposes that the lead agencies are reporting to MCYS. At this point, these are in aggregate, but we are exploring ways in which we might be able to integrate some of those data with those of our own. And again, wait times, top of the list in terms of what people, what we know is one of the biggest issues for children and youth and their families. And so this is the first year of wait times data from the lead agency. So these are mean wait times that range anywhere from 2 days to crisis services up to 98 days. And this really, provides that first look against which many initiatives and improvement will be judged. Just to highlight a little bit around the data integration, so we were very fortunate, even before the lead agency transformation, to work with what is now a lead agency, the Keynote Child and Family Services. They had an excellent IT system which allowed integration of the data of their clients with the healthcare data at ICES. And really, this is just a very small snapshot, but you can imagine, how powerful it will be when we are able to, link some of these data so that we understand, are the children that are being served by the lead agencies the same ones being served by the healthcare system, or are they different? How are some of these children who are being seen in the emergency departments after hours, are they being appropriately referred to some of the community-based agencies? And then, other issues around, once children and youth turn 18 and age out of the child and youth community agency system, how are their outcomes as we can measure them in the healthcare system? So this is just data to show. These are in the royal blue is what healthcare, so ED visits or hospitalizations prior to children and youth coming to KINARC. The lighter blue is during, and then yellow is after. And you can see that you can track very nicely what the concurrent sort of healthcare use and outcomes are during treatment and then after treatment. Finally, always nice to end with a bit of a high note, just a few of the indicators that we think measure very directly some of the investments that were made during the mental health strategy. So as many of you know, there was a direct investment in inpatient beds for eating disorders. This was an area where access to inpatient care was limited. Ontario was sending a number of children and youth down to the US for treatment because of the lack of beds. And we've seen a nice upswing in the use of inpatient eating disorder beds for children and youth in Ontario, and Paul's done nice work to show, a concomitant decrease in the number who have to go out of province for that care. Again, I spoke, it's a little hard to know how to sometimes interpret, more care, is that a good or bad thing? But we would suggest that knowing everything that we know about the increasing need, or at least the unmet needs, to see that there's been an increase in the number of children and youth who are able to access specialized psychiatric services, we think is certainly is progress. And then finally, we are starting to see more children who have access care before they end up in the emergency department. So again, probably, the result of reducing stigma and making sure that children and families do access care before problems become terribly acute. Where are we going? Just to highlight a few of our directions. So we are committed to, redoing this scorecard to measure progress of the system every 2 years. But really, we are spending a lot of time trying to improve the kinds of data that we have, that we're able to, really report more robustly. Just a few examples. Minister Bell talked about the narcotic monitoring system. We have that now in-house, and that will certainly be useful to understanding, the piece around opioid addictions. We're very pleased that we're almost finalized with our data sharing agreements with the institutions that provide telemental health services to children and youth. This is funded by the Ministry of Children and Youth, and we think it'll be very important, especially in addressing some of the unmet needs around the North, to be able to report that important piece of care that we're not able to report. We are developing a partnership with the Minister of Community and Social Services, which again will be very helpful in understanding some of the families in need, as well as some of the details around drug prescriptions for those who are under 65. And finally, just to highlight, we've finalized a data sharing agreement Ministry of Education around the Early Development Index. This is about senior kindergarten readiness, but we do, this is our first step in really engaging with that ministry around schools, and which we know are very important for the understanding of child and youth mental health. And then finally, and just as a segue to Paul's talk next, you know, there is a larger performance measurement initiative in the province that includes adults, and, you know, we work together very closely as a team, and we want to align this sort of measurement, you know, carefully. And with that, I will turn it over to Paul. Thanks.